Hypothalamus artificial intelligence. Digital transformation powered by real-time autonomous and intelligent algorithms. Presents its solutions for Pandemic Management Decision Support System. Part 4. Epidemic Economic Impact Model. The presentation consists of 5 videos, and their supporting documents, which summarize all the applied research work carried out by HI, to contribute its knowledge in highly complex mathematical modeling, to the optimized management of pandemics such as COVID-19. These are: Pandemic Management using Advanced Artificial Intelligence, Epidemic Simulation Model, General Epidemic Optimization Model, Epidemic Economic Impact Model, and Kalman Filter Estimation Model of the Epidemic State. The models corresponding to Part 4 and 5 are designed, but have not been implemented. Hypothalamus Artificial Intelligence thanks the support received from Tecnológico Nacional de México, who partially financed the implementation of the SEIMR/RS and SERM/RS/OPT models. Specifically, HI thanks the staff of the Instituto Tecnológico de Ciudad Madero, who actively participated in the project, and was the way to receive this support. Users of these mathematical models can be grouped into information technology companies, government, universities and research centers, and private enterprises and gremial organizations. The result of the research and mathematical models carried out by Hypothalamus Artificial Intelligence, it is considered a public good, because it is of benefit to all humanity. Therefore, HI is willing to offer them at no cost to nonprofit organizations, mainly in developing countries. HI is also interested in being part of research groups working on pandemic management. Conference prepared and edited by Jesus Velasquez Bermudez. His resume can be found on LinkedIn. A different paradigm for epidemic management. As Albert Einstein put it, to raise new questions, new possibilities, to regard old problems from a new angle, requires creative imagination and marks real advance in science. The decision-making during the pandemic process aims to make the best decision for society, which is not easy, nor intuitive. The problem is further complicated, when decisions must be made with real constraints on available resources, and when it must consider the socio-economic impact, derived from the pandemic and its control. The traditional goal of pandemic management focuses on modifying the natural behavior of the pandemic, solid curve, through sanitary controls, in order to reduce the peak of infected people, striped curve, and thus save lives by reducing the deficit of hospital resource capacity. However, it should be noted that the two curves have the same integral, and in theory when time tends to infinity, the amount of the infected population will be equal. If hospital resources are sufficient, there is no reason to delay the peak, and as the pandemic spreads, the negative socio-economic impact will be greater. The traditional tool is to use simple epidemic simulation models, trying to predict the future of the pandemic, before different control measures, and thus select, based on perception, which is the best decision. The simulation models, traditionally used to make decisions to control the pandemic, correspond to tools of low mathematical complexity. This is because simulation models do not have an optimization capability, and leave the decision in the hands of the human expert. In this way, the expert tests multiple scenarios, and in a finite time, selects the one he considers the best decision. Economic and social added value by mathematical methodologies. The analytics landscape diagram presents IBM's vision regarding the value added by the different methodologies that integrate analytics, or artificial intelligence. Not all methodologies produce the same ability to handle complexity and achieve competitive advantage. This cannot be ignored by public health officials, as the absence of adequate mathematical methodologies translates into greater negative impacts, deaths and loss of quality of life. On the other hand, optimization models iterate internally at the calculation speed of the host computer, and based on strict mathematical laws, if time permits, they will come to propose the best decision that can be made, according to the decision-maker criteria. The difference between the two decisions will simply mean fewer deaths, or lives saved by highly complex mathematical methodologies. When all the models that make up a company are solved using the concepts of real-time distributed optimization, an artificial hypothalamus is obtained. In the case of the epidemic, Hai has conceptualized the epidemic management hypothalamus based on 4 models: epidemic model, logistic model, economic model, and control and surveillance model. This video is related with the logistic model. The following uses as a reference the results presented in the technical report, Impact of Non-Pharmaceutical Interventions, NPIs, to Reduce COVID-19 Mortality and Healthcare Demand, published by the COVID-19 Response Team of Imperial College, IC. The C researchers studied, using epidemic simulation models, 5 intervention policies to control the pandemic. It can be said that the best policy for the management of a pandemic is to apply dynamically multiple of the available policies. However, finding the dynamic combination of policies is not an easy problem. Below is an analysis of a report conducted by Imperial College, at the beginning of the COVID-19 pandemic. The graph presents the simulation of control strategy scenarios for ICU bed requirements. The black line shows the unmitigated epidemic. Green shows a suppression strategy incorporating closure of schools and universities, case isolation and population-wide social distancing beginning in late March 2020. The orange line shows a containment strategy incorporating case isolation, household quarantine and population-wide social distancing. The red line is the estimated surge ICU bed capacity. The blue shading shows the 5-month period in which these interventions are assumed to remain in place. B shows the same data as in panel A, but zoomed in on the lower levels of the graph. Analyzing the results presented, we have: if one considers that there are long periods in which the health system has excess capacity, and a concentrated period with capacity deficit, in which many people die, the simulation policy involves inefficient use of available capacity. If physically possible, controlling the spread of the pandemic, we should try to reduce the peak, modulating in the time the curve of infected, so that the usage factor of the system tends to be uniform throughout the pandemic. This would decrease the number of dead, and decrease the capacity expansion requirements of HMS. The same can happen from the spatial point of view. If symmetrical control measures are applied in 2 regions that share health resources, for example, doctors, ICUs, ambulances, etc., it should come as no surprise that despite decreasing the total peak, it is concentrated in same period in both regions. Perhaps the best solution may be to plan that the pandemic peak to occurs asynchronously in the 2 regions. Optimal pandemic management involves increasing response capacity by making investments to increase resources at the appropriate times. That is, we must respond, how much, when and where to increase health resources. Given the always limited capacity of money for investment, this will have to be answered as it is done today, using mathematical programming models. The graph visually presents the situation. Each possible expansion of capacity will produce a different amount of avoided deaths, and the value of the investment. Given that investments must be made in different regions, and that the epidemic is different in each region, the problem is highly complex. On the other hand, if mobile resources are available, the time they are allocated to a region must be optimized, since allocations can be made at times when the marginal reduction of deaths is 0. In order to quantitatively estimate the impact of highly complex mathematical modeling, reference is taken of the results presented by Imperial College, which contains comparative results of 4 management strategies for COVID-19 pandemic. The strategies analyzed, with a simulation model, are: NOTH, do nothing. ZCTP, low/0 math complexity, based on the traditional practice of total quarantine, which can be considered as 0 level of mathematical complexity. From mathematical point of view, it corresponds to a simulation of a traditional practice. MCSM, medium math complexity, it combines total social distancing control policy with mitigation based on prohibiting activities that generate crowds, colleges, universities. Medium level of complexity, it can be solved with math simulation models. HCOM, high complexity, it tries to determine the best mix of control policies. The IC used a simulation model to obtain this results. They may be optimal, but, due to that it is high complexity mathematical problem, to solve it exactly it is necessary to use high complex optimization algorithms. The results establish an upper bound for the minimum number of deaths. This codification was made by the Ing. Jesus Velasquez, not by the IC researchers, that uses another codification rules that is showed in the header of the next table. IC analyzed 20 experiments, combination of diffusion factor and entry speed, triggering. The table, extracted from the C report, presents the results for the 80 reported experiments, which arise from the combinatorics of 4 control policies, 4 values of R0, and 5 entry speed, on trigger. The results are presented in terms of dead, ICU demand and proportion of time with social distance in place. The table, prepared by High, presents the comparison of the results for the different levels of mathematical complexity, deaths and confinements. For this reason, it is necessary to obtain more complex control policies, which evaluates the combinatorics of all alternatives. The limitation to achieve the best solution is related to the real modeling of the pandemic, and the little ability of simulation models to obtain optimal policies. There is no rationality that justifies not using highly complex optimization models to support the decision-making process during a pandemic. Its costs are more deaths than the minimum possible. These models should be declared a public good. The benefits of highly complex mathematical methodologies are lives saved and more effective economic protection. Optimizing the pandemic decision-making process. There is no rationality that justifies not using highly complex optimization models to support the decision-making process during a pandemic. Its costs are more deaths than the minimum possible. These models should be declared a public good. Epidemic decision support mental system. An example of an apparently good decision to control the pandemic, but which can be counterproductive, may be non-selective confinement. According to mental models, confinement can hardly be questioned as a good measure for the pandemic. However, the effects of confinement are very different depending on the economic strata of the people who live in a household. In the strata of high economic power, who live in houses with great extension, the natural separation of people, little is affected, to the extent that they live in areas with more square meters. Additionally, it should be noted that in these strata, the need to go out can be controlled for long periods. In the low net worth strata, the situation is very different. They live in areas of a few square meters, for example in 25 square meters can inhabit up to 10 people. Additionally, many of these people must go out every day, to the street to look for some income, otherwise they could not live. This situation leads to confinement increasing the closeness between people, throughout all day, which increases the probability of contagion. On the other hand, the need to leave exposes, at least one person, to the virus circulating in the region. Together the two situations, the probability of contagion of all those who live in such a small space, increases significantly. An appropriate mathematical model can quantitatively discriminate this decision. SEIMR-RS, General Epidemic Model. SEIMR-RS corresponds to a generalized mathematical model of pandemics that enhances traditional, aggregated simulation models when considering interregional impacts in a macro region. SEIMR-RS also considers the impact of modeling the population divided into socio-demographic segments based on age and economic stratum. It is possible to include other dimensions, for example, ethnics, gender, etc. SEIMR-RS is the core of the SEIMR-RS OPT epidemic management optimization model, that determines optimal policies, for example, mitigation and confinement, considering the spatial distribution of the population, segmented socio-demographically. Since SEIMR-RS OPT model is an optimization model, the best way to joint the two models is to program them in an algebraic language, like GAMS, AMPL, IBM OPL, Mosel, etc. This involves embedding a model of finite differences within an optimization model. More information about this model can be seen in another video. The image shows the state transition diagram for SEIMR-RS epidemic model. SEIMR-RS OPT, General Epidemic Optimization Model. Fundamentals. SEIMR-RS OPT is the decision support system developed by High for the optimization of pandemic management. SEIMR-RS corresponds to an epidemic model of differential equations, which considers multi-infected states, multi-socio-demographic segments and multi-region mobility. OPT is related with the optimization of optimal control policies and health resource capacity expansion, considering the epidemic model SEIMR-RS. The models were developed taking as reference the metropolitan area of Tampico, Ciudad Madero, and Altamira in Mexico, and the city of Bogotá in Colombia. They were applied at an experimental level and are not part of the analytical tools used by health authorities in these regions. The artificial hypothalamus of a pandemic decision support system is conceived by HI, based on a multi-layered mathematical model, which expands as the scope of decisions it must support grows. The layers considered are supported in the following models: epidemic simulation, control policies, system capacity expansion and management, and socioeconomic impact. For a holistic view of the process, impacts should be visualized on the epidemic, the health resources, the micro-macro economy, and the optimal strategy to face the epidemic. This holistic vision allows the authorities responsible for public health to visualize the general quantitative impact of the pandemic, and not only limit themselves to the simulation and try to control it with decisions based on mental models, which in complex situations have been proven not to be the most indicated, and in many cases counterproductive. Pandemic logistics management. The logistics layer of the SEIMR-RS OPT aims to include in the management of the pandemic the use of critical health resources to help minimize the number of deaths, considering the supply chain of vital health services. The modeling is aimed at coordinating pandemic management with the physical vital resources required to minimize the impacts due to the pandemic. It must be clear that managing the epidemic is indirectly managing resources, and that the availability of resources must be considered when managing the epidemic, as it is known that the peaks of the epidemic are a consequence of the control policies selected by public health authorities. Coordination of the two aspects is essential to minimize the deaths due to the epidemic. SEIMR-RS OPT model has been published in the special edition of the European Scientific Journal, Public Policies in Times of Pandemics. The document, SEIMR-RS OPT, Epidemic Management Optimization Model, Control Policies, Vital Health Resources, and Vaccination Theory, corresponds to the optimization model, which integrate the differential equations model, for the optimal management of pandemic processes. SEIMR-RS OPT, General Epidemic Optimization Model. Fundamentals. SEIMR-RS OPT is the decision support system developed by HI, for the optimization of pandemic management. SEIMR-RS corresponds to an epidemic model of differential equations, which considers multi-infected states, multi-socio-demographic segments and multi-region mobility. OPT is related with the optimization of optimal control policies and health resource capacity expansion, considering the epidemic model SEIMR-RS. The models were developed taking as reference the metropolitan area of Tampico, Ciudad Madero, and Altamira in Mexico, and the city of Bogotá in Colombia. They were applied at an experimental level and are not part of the analytical tools used by health authorities in these regions. SEIMR-RS OPT is a high-complexity mathematical model oriented to coordinating pandemic management with the physical vital resources required to minimize the impacts due to the pandemic. It must be clear that managing the epidemic is indirectly managing resources and that the availability of resources must be considered when managing the epidemic, as it is known that the peaks of the epidemic are a consequence of the non-pharmaceutical interventions, NPIs, policies selected by public health authorities. Coordination of the two aspects is essential to minimize the deaths due to the epidemic. To assess the impact on the health system due to the management of other diseases other than the main epidemic. The decisions of health authorities can increase deaths from diseases other than the epidemic, by limiting the access of these patients to vital health services. The management policy of the pandemic should consider the expansion of capacity of vital resources, the scarcity of which generates additional deaths, and the adequacy of complementary resources to such expansion, in accordance with the development of the pandemic. The table presents the indices used to sub-indicate the algebraic elements of the mathematical model. Each index corresponds to an entity in the information system. The table contains supplemental information such as relational key, master tables, and entity code. To measure the impact of logistic aspects on the epidemic model must be adjusted to reflect its impact on the number of deaths. The basic epidemic modeling only can represent an epidemic process, without considering how the installed capacities of vital health resources affect the natural epidemic process. When the capacity of a vital resource is exceeded, for example the number of beds for care for severe patients requiring intensive care and/or intermediate care, ICU, the probability of transition between states is changed. This can be modeled directly, building capacity-dependent rates simulating the process that occurs. For this it must be considered that there is the possibility of dying before reaching the most critical of the epidemic disease, N. This early death can occur if vital life-sustaining resources are scarce. The mechanism is to include the MD state, which accumulates the dead for reasons of pandemic management. One goal of the planning is to minimize the total dead in state MD. The modeling approach is to introduce the concept of alternative state, to which, with probability 1, is directed the population that cannot be served by capacity deficit. This state must be a new state that receives the population of the state chain itself, plus the forced transfer due to the capacity deficit. Then 2 additional states must be included in the epidemic model. IU infected unattended. MD epidemic collateral deaths, caused by reasons other than the epidemic, mainly due to capacity, or by management policies. It should be noted that the number of deaths directly generated by the epidemic, ED state, corresponds to a constant value, independent of the management of the epidemic. Therefore, trying to minimize this number of deaths cannot be the goal of optimization. If nothing is done and the number of resources remains constant, the ED value will also correspond to a constant value. However, managing installed capacity over the planning period can decrease the number of deaths occurring in the MD state. SEIMR RSOPT is the union of 2 models, modified epidemic and logistic. Control policy modeling. The objective of the control policy is to regulate the epidemic, in such a way as to minimize the number of deaths due to factors other than the epidemic, deaths in MD state. According to social estrangement, control policies are classified as confinement, fully isolates the socio-demographic segment that are the subject of confinement policy. It is characterized by 2 confinement policies, or more, cannot be applied to the same socio-demographic segment in a region, and if confinement measures are applied, mitigation policies are not applicable. This policy is disjunctive, it is applied or is not applied, then, it corresponds to a binary variable. Mitigation decreases social contact, limiting social activities involving agglomeration, for example, attendance at schools, universities, bars, restaurants, etc. This policy may be continuous, applies to a fraction of the population, varies between 0 and 1. The effect on the spread of the epidemic is linear, as the intensity of mitigation increases, the rate of spread decrease, and discrete, applies to the entire population, is represented with a binary variable that is 1 if policy is activated. Diseases control policies of the use of health services by restricting the care of certain diseases, with the idea of reducing contagion and expanding the patient care capacity of the epidemic. The implementation of these policies may involve the formation of care queues for patients, who may end up leading to additional deaths to the natural in such diseases. The table presents the variables used for the implementation of confinement control policies. Deaths for reasons other than the pandemic. The hypotheses made for modeling the impact of the epidemic on other diseases are as follows. The diseases, or pathologies, considered have a natural rate of patients classified in critical, patients who urgently require health services, and who compete with the sick of the epidemic for vital resources. Some of these patients will die for health reasons, and others will die if they cannot access vital services, within a limited period. It implies that the model must manage queues of unattended critical patients, and moderates, patients who require health services for recovery and who, if not cared for within a period, will become critical patients with the chance of dying. It implies that the model must manage queues of unattended moderated patients. The deaths of the previous patients are counted as follows. Critical patients who must die for reasons of their illness are counted as natural deaths. Critical patients who die from not being able to access vital health services are counted as dead due to epidemic management, and moderate patients who are not treated in time will become seriously ill, and if they die, their death will be counted according to the above hypotheses. Pandemic Logistics Management. The logistics layer of the SEIMR RSOPT aims to include in the management of the pandemic the use of critical health resources to help minimize the number of deaths, considering the supply chain of vital health services. The modeling is aimed at coordinating pandemic management with the physical vital resources required to minimize the impacts due to the pandemic. It must be clear that managing the epidemic is indirectly managing resources, and that the availability of resources must be considered when managing the epidemic, as it is known that the peaks of the epidemic are a consequence of the control policies selected by public health authorities. Coordination of the two aspects is essential to minimize the deaths due to the epidemic. To coordinate the two models, the patient's source epidemiological status must be differentiated into a different disease, in such a way that they return to the state of origin. If they do not die in the disease process, only the susceptible, SU, and the recovered, RE, are considered as source states. And they are the link with the epidemic model, SEIMR RSOPT. In the SU and ER states, patients can become ill with other diseases, entering in a moderate, or a critical, state of that disease. Critically ill patients may die from the disease, going to DD state. If the available resources, mainly ICU beds, the sick should go to a queue, and if they die, they should go to state XD. The image presents the connectivity of the two models, epidemic model and other disease model. The sum of the dead in the MD and XD states are attributable to the management of the pandemic. Health resources are divided into two types. Vitals, a subset of resources whose scarcity is reflected in the change in epidemic status of affected patients, increasing the number of deaths for reasons other than the epidemic, and complementary, resources whose scarcity creates management problems, but do not affect the development of the pandemic. The consumption of resources is directly proportional to the people in each state of the pandemic, and other diseases. Two equations are required to relate the two models. Calculation of total resources demanded, and the limitation of the consumption of resources according to their availability in each region. This equation indirectly limits the number of people in the different states of the pandemic, which will force patients to move to queues, waiting for the release of resources. To reduce the people in queue, the capacity of attention must be expanded, through the purchase of health vital resources. This requires the following considerations: increase available capacity summing the number of expanded resources, variable EXC. Cost the expansion, SEX, according to a general cost structure, consisting of a fixed cost, COFX, plus a variable cost, CORE. For modeling, the binary variable EXP is required, which activates the fixed cost. Finally, investments must be limited to the available budget. Alternatively, the model can calculate the budget required to assist the pandemic, under a maximum number of deaths, or another similar indicator. Computational implementation. High rigorous algorithms are defined for each real case. All high solutions are produced by Optex. Optex, Optimization Expert System, is the high artificial intelligence that manufactures decision support systems. High Health integrates with High HRPO. This implies that all models of the two systems can be integrated through the database, via a common data model, and by means of equations that integrate a unique holistic model, this following the principles of structured mathematical modeling. This integration is since the management of public health problem corresponds to regional planning problem, as experienced during the COVID-19 pandemic. The screenshot presents the master table of the age segment, and its relationships with other entities, scenario, groups of hours, and socio-demographic segments. The screenshot presents the header of the GAMS program of SEIMR RSOPT. The screenshot introduces some restrictions of the SEIMR RSOPT GAMS program. Hypothalamus Artificial Intelligence. Invites to join to the LinkedIn group. Mathematical Modeling for Coronavirus Pandemic. Like Herbert Simon, Hypothalamus AI believes that the computer-based mathematical modeling is the greatest invention of all times. Thank you for your attention.